Deepika Kedia, Dr. Ranajit Chatterjee, and others for organizing this monthly webinar on behalf of the Royal College for the promotion of medical education and clinical skills in the Indian subcontinent. For all medical students who wish to carve out a future in clinical medicine, the ultimate goal ought to be the MRCPI, the membership of the Royal College of Physicians of Ireland, which is recognized around the world as an international benchmark of excellence in medicine, opening up new opportunities for the career advancement. By successfully completing the MRCPI exam, you are joining a global network of respected physicians whose roots date back to the year 1654. It also sets you on the pathway to Fellowship of the Royal College, a career milestone and an international benchmark of professional excellence. Our fellows are experienced hospital consultants who have made substantial contributions to their specialty. Globally, there are more than 11,000 fellows, members, licentiates, and trainees in 84 countries. Today, as you know, we are in the midst of a mind-boggling age of unending information, knowledge, and technological ferment. And webinars like this one by the RCPI are the need of the hour for disseminating and sharing practical knowledge and wisdom amongst us clinicians, so as to equip us to effectively face the day-to-day challenges in the world of Medicare. I recall what a wise teacher had once said: the human mind is like a parachute. It works only when it is open. On our monthly platter, we have three interesting dishes today. Number one, first we will be enlightened on medical negligence, its legal liability, and its significance by Dr. Sagarika Mukherjee, who is consultant endocrinologist at the Columbia Asia Hospital, Kolkata. Dr. Deepak Sharma, consultant cardiologist from Christian Mission Center Hospital, Jorhat, will be chairing this session. Next, we have nephrotic syndrome in the pediatric age group by Dr. Sushmita Banerjee, consultant pediatrician at the CMRI Hospital, Kolkata. As chairperson, we will have Dr. Bijan Bhattacharya, head of the Department of Nephrology at the Ruby General Hospital, Kolkata. And finally, on the diabetes front, Dr. Manojit Ketan Mukhopadhyay, consultant endocrinologist at the AMRI Hospital, the Kuria, Kolkata, will update us on GLP-1 RA's future of incretin-based therapy. As chairman for this session, we have Dr. Devmalya Sanyal, consultant endocrinologist at the Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. Wishing you all a very fruitful and enriching update. I will now conclude with some words of wisdom by James Corbett. To become a champion, fight one more round. This is for the students. Thank you.
Thank you, Professor Jain, again for such wonderful introduction. May I now invite Dr. Sabyasachi Ray to say a few words to the assembled delegates.
Good evening, everyone, once again. For this 6th webinar, it's my proud privilege to be present here to introduce Royal College of Physicians of Ireland, who is the oldest medical institution of the world, which completed 365th year this year. We were officially inaugurated in 2005 with an Indian chapter in Kolkata, and since then we have been engaged in doing MRCP examination organization in all parts of the MRCP, as well as CME and seminars by ourselves and in association with the institutions and universities of India, as well as the neighboring countries like Bangladesh, and until the whole problem was stopped by this unfortunate pandemic in March 2020. Then we were lying idle, and our life was very difficult professionally and personally. In September 2020, we decided to continue our exercise. The only possible way at that time was to go by webinar, and that's how we started in September. This is the 6th one, and I'm sure today's the excellent program that we have will take home a lot of information which is useful for us for present and future. Without further delay, I'll hand over this mic to Dr. Sujoy Majumdar for further proceedings of the evening.
Thank you, Dr. Ray. So without wasting much words, let us get back to the main seminar. And the first topic that we are going to talk about today is on a very vital issue, that is the medical legal issues that we face. And the chairperson for the meeting is Dr. Deepak Sarma and Dr. Sagarika Mukherjee, who is a well-known to us. Basically, Dr. Sarma, just a few words. He's a consultant cardiologist at the Christian Mission Center Hospital, Jorhat, and he has been the past president of the Assam Cardiological Society and Cardiological Society of the Indian chapter. He has been elected to the Executive Committee of the Cardiological Society of India. He has been a faculty of PHFI for quite a while, I believe since 2011. He's edited 4 cardiac update books. He has been a contributor to chapters in the various update books and the CSI textbook of cardiology. He's acted as faculty in various national and international meetings, and he has been a national advisor to the Indian Heart Journal. So quite, I should say, a very bright CV, of which we all are proud of. The speaker today is Dr. Sagarika Mukherjee. Sagarika, as we all know, she has been associated with us with the Indian chapter ever since its inception. She's a consultant physician in endocrinology and diabetes at AMRI hospitals and Columbia Share hospitals. She has a special interest in thyroid disorders, lipid disorders, and pregnancy and diabetes. She had received the highest specialist training, that is CCST in endocrinology and medicine from United Kingdom. She has got numerous presentations in national and international diabetes and endocrine conferences and several publications in peer-reviewed journals. She has been the treasurer of the Indian chapter of the Royal College of Physicians of Ireland and an examiner of the Icrcpi examinations. She has been a teacher and facilitator of the CCAD course of the Public Health Foundation of India. So again, quite a glowing and testimony to her credentials. So with these words, may I invite Dr. Sarma to say a few words on the topic and give Sagarika the lead.
Thank you, Dr. Sujoy, for your nice introduction. It's really a pleasure to join you again in the Zoom meeting, but unfortunately, I'm invisible, I suppose, something is wrong with my computer, I suppose. Anyway, I think I congratulate the RCPI because of, organizing this excellent menu of the topics. I think the first topic, of course, is the medical negligence. As we all know, that we are supposed to be the noblest profession of this world. However, more and more we are falling victims of cases of medical negligence, and apparently there are about more than 50 lakhs cases of medical negligence recorded every year in this country. So it's a very hot topic and burning topic. And apparently, every minute, 10 people fall victim of medical negligence. Well, unfortunately, most of our professional colleagues are not aware of the nuances of the medical negligence. So to take us through the various aspects of medical negligence, we have a very eminent speaker today, Dr. Sagarika Mukherjee. Sujoy has already introduced her. So without much ado, I suppose we can start the meeting straight away. Thank you.
Thank you very much, the Royal College platform, for calling me again to talk. I feel really very obliged to come here time and again to speak, and thank you very much, Sujada, for the kind introduction. Since medical negligence has been a very widely discussed topic amongst the medical fraternity, and some of it we understand that whether the doctor has been at fault in dealing with the patient, and sometimes there isn't any fault, and yet the doctor falls trapped in this negligence thing, and we really don't, as a medical professionals, don't fully understand the legal liabilities that we need to take and what are its significance. I had some personal, well, not personally for myself, but with a very close person associated with got involved with medical negligence cases. And we have been very, very perturbed with this. And I wanted to understand that exactly what are the nuances of medical negligence? How do you go about it? And this made me to take up a course. And I had done a course called the Postgraduate Diploma in Medical Law and Ethics from the National Law University in Bangalore, the PGDMLE course. And really, it was an eye-opener for me. Not that with this course I can be practicing law in a courtroom, but definitely it gives you a different sort of idea that how you look into medical negligence, what are the things that we have to understand, how do doctors protect ourselves. And this is just a small part that I'm going to talk about, really a tiny grain that I'm going to talk about medical negligence, just to give you an eye opener what sort of things that you can expect out of it. Right. What do you understand by negligence? Now, as a lay person or even as a medical person, understanding negligence is quite different from how a lawyer understands negligence. So negligence is something which is like a breach of duty. What is that breach of duty? You are obliged to, you are duty bound, or you're obliged to do something to a person, and yet you do not, you do not commit yourself to do that thing, and therefore there is a breach of your duty. And that breach is understood by a reasonable man. Now, there is a catch in this term called the reasonable man. How does the law define a reasonable man? The reasonable man is that the law usually understands that what an ordinary person would do in the ordinary circumstances. If you fail to do that, then obviously you are negligent of your action, and therefore you are bound to be charged for it. So negligence is a breach of duty which is caused by omission to do something which a reasonable man, we are guided by those considerations which ordinarily regulate the conduct of human affairs, would do, or doing something which is prudent and a reasonable man wouldn't do. So what is actionable negligence? That is a negligence under which you can be really, litigation can be brought under it. Under ordinary course, if you don't do anything which a reasonable man or just under ordinary circumstances you would have expected to do, if you don't do this, then obviously you are breaching your duty, and therefore an action can be brought against you. So this liability or the negligence generally comes under tort law. So the constituents of negligence, you have to understand the three ingredients must be fulfilled so that a tort of negligence can be brought. So what is it? You have a legal duty to exercise due care. Say, for example, a doctor has a due care towards the patient. The doctor has a due care to perform the duty towards the patient. Now, you do not perform the duty. Say, for example, a person coming to you with a simple headache. You are duty bound to prescribe some paracetamol, just in simple circumstances I'm causing, but not going into investigation or anything else. You're duty bound to perform, to give him at least some simple medication to alleviate his symptoms. Say, for example, you have to prescribe paracetamol. You do not prescribe paracetamol, therefore you are breaching that duty. So you had a duty of care, you breached that duty, and because you did not prescribe him, he suffers some sort of damage or some sort of injury, which means that some sort of consequential damage because of that breach of duty, and therefore you incur the liability of a negligent tort upon you. So these three things must be fulfilled. There is a duty of care you owe to a person, there is a breach of duty of care, and there is a consequential damage. A damage has to be caused, otherwise the tort of negligence doesn't happen. However, the doctor is not always liable in all cases where the patient has suffered any injury. There must be some valid reasons or some valid defenses where he hasn't breached the duty of care. So there can be an error of judgment. What is it? The error of judgment is recognized that it's not supposed to be a duty of care. Say, for example, a person comes with a pain abdomen. The doctor thinks that it could be a gallbladder pain, whereas it is a UTI. But just with simple symptoms, the doctor may not be able to judge that. Say, a newly qualified doctor, that isn't his breach of duty. That error of judgment doesn't fall within the ambit of breach of duty. The breach of duty would be if he did not pay any attention to the pain abdomen of the patient, which he was supposed to do. That is breach of duty. Now, error of judgment due to negligence, if the doctor did not pay too much attention to the patient, did not make a diagnosis properly, did not pay much attention to the patient, and therefore the diagnosis of the patient was missed, then that amounts to negligence, and that amounts to breach of duty, and therefore you can be sued. So medical negligence really can happen in a number of ways. So the common occurrences are wrong diagnosis, patient is not diagnosed with the proper disease and therefore not treated properly. Wrong diagnosis makes things even worse and causes more injury to happen. There can be a delay in diagnosis, that is, the patient comes to the doctor with some condition, and because of the doctor did not have enough of an experience, or the doctor did not know what to do or did not seek adequate help, and therefore the diagnosis was delayed. That can lead on to negligent action. Error in surgery. This is a very common occurrence for negligence cases to occur. Like surgical operation, it requires an enormous amount of skill which is involved, and you must really exercise an enormous amount of care so that the patient can get better. So the slightest error in surgical procedures can really lead to negligence. Say, for example, you perform a surgery on the wrong limb, on the wrong person, you leave a mop inside the abdomen, or you perform a surgery which incurs severe blood loss, etc. That amounts to negligence. Unnecessary surgery, where if you don't diagnose the patient properly but leading on to unnecessary surgical procedure, that can be a negligent action. Errors in administration of anesthesia. This is again a wide area of negligence, especially in surgical practice. The anesthetist, many a time, especially in busy private practice, you might see, those of who are involved with surgical practice, you might see that the anesthetist really doesn't do a proper pre-anesthetic checkup, which is supposed to do at least a day or a couple of days prior to the operation. The pre-anesthetic checkup might be done about an hour or so before the operation, and if the patient has got certain conditions, say for example a heart condition or a lung disease, which the anesthetist misses out, and then during the course of anesthesia he administers the wrong anesthetic drug and the patient ends up in trouble. Childbirth and labor is another area where a lot of negligence can happen, because of the doctor might be a bit laid back, doctor might not pay a lot of attention to it, and the mother goes into prolonged labor or traumatic labor and can lead to a deformed child, etc. And of course, long-term negligent management. Say, for example, you do a misdiagnosis, manage the patient improperly for a prolonged period of time, and that can incur further damages. So the liability of the doctor lies in the three areas. One is doctor has a duty of care in deciding whether to undertake the care. A patient comes to you. You are in position to decide whether you are going to undertake the patient for treatment or not. There lies the duty of care. You also have got a position that you can refuse the patient as well. I will be discussing just shortly when you can refuse and when you cannot refuse. When you have already undertaken the patient, you owe a duty of care to the patient to give the treatment to the patient. Because once you have taken the patient on board, you are bound to give some form of treatment to the patient for which the patient has come to you. Next is duty of care of administration of treatment, what form of treatment you are going to give. So these are the three liabilities of the doctor for the duty of care. So the duty of care is the first stage when you decide to undertake the patient. When the patient walks into your chamber, you see the patient, and the patient voluntarily walks into your chamber. Therefore, you haven't called in the patient. A patient might be coming to the hospital where you are employed under the hospital administration. So you have a duty of care to take up the patient in deciding what form of treatment you're going to give. Under normal circumstances, normal circumstances means when there is no emergencies, things can wait, you can take a lot of time to decide about the patient. Under normal circumstances, you may or may not take up the patient. Say, for example, you don't like the patient, you may not, a patient has come to you, say, not understanding that a pain abdomen, and yet you're a physician, you may refuse to take the patient and refer the patient to a surgeon. You are not negligent of any action at all. Under normal circumstances, the doctor does have a choice to exercise whether to take the patient up or not. However, if there is a medical emergency, any MBBS doctor, any doctor who has got a medical qualification is bound by law. This is a Supreme Court declaration. You are bound by law and there is no discretion. You have to give emergency medical care to the patient. If you do not have the expertise, like a lay person, as a lay person would act in an emergency, give first aid care, you're bound to give that. And then you have to refer the patient appropriately until and unless the patient is taken up by the referral center. It is your duty to really safeguard the life. And there are there are really several number of landmark cases which has been decided by the Supreme Court. One of the cases was like Paschim Banga Khet Mazdoor Association Committee, where a person who had person from Midnapur had sustained a road traffic accident. He was brought and then he was refused in the state hospitals, that is the government-run hospitals, saying that they did not have any neurosurgical facilities available in their center, and the patient was referred to Kolkata to attend other hospitals. And the patient in that head injury condition really had to roam in each and every government hospitals and he was refused treatment. And finally, this patient was accepted in Calcutta in CMRI hospital, and he had incurred a huge bill because of his treatment. A beneficial person, he had launched a public interest litigation in Supreme Court around 1995-96, saying that a person, the state is responsible to its citizen. Being a welfare state, excuse me, I'm having a phone call. Being a welfare state, we do have responsibility towards our citizens, and therefore it is the state's duty to arrange for the welfare of the patients and also for their well-being. And it was the state's responsibility that neurosurgical facilities should have been made available. And then the Supreme Court had made a declaration that under no circumstances, if the patient is in an emergency, any doctor must really attend to the patient, and at the cost incurred, if the patient cannot bear the cost, regardless whether the patient has insurance, regardless what is the financial status of the patient must be treated. And later on, if it is a private medical setting, the cost can be reimbursed. So the stage 2 comes in when deciding what form of treatment to give. So once you have accepted the patient, you must know what form of treatment to give to the patient, because if you do not know, you are duty bound, you have a duty of care to offer the patient what form of treatment you are going to give. And then the stage 3, which is again the most important stage, the actual form of administration of the treatment. So if a doctor fails to perform any of these stages, then a breach of duty comes in. And then once there is a breach of duty and if the patient gets injured from this breach of duty, then obviously he is negligent. So for example, if we take up the case of Kushum Sharma versus Batra Hospital, which was held that in the Supreme Court, that if a doctor finds out about a procedure which involves a higher element of risk, and the doctor believes that taking up such a high degree of risk might relieve his patient, and during the procedure, if some mishap happens, the doctor will not be held negligent because he was doing that in very good faith in bringing out the best of outcome of the patient. But again, that outcome is not always involved with the doctor. There are some other circumstances as well which has to be taken into consideration. In another case, like Jasprit Kaur versus State of Punjab, a child who was born into the hospital was found missing from the bed of the mother, and then the child was found bleeding near the wash basin. The hospital authorities had argued that the child was taken by a cat, which has caused him damage. But however, it was the hospital authorities' duty that the child who was born in their hospital to safeguard the child, to look after the child properly, protect the child properly, and not that a cat can take away the child or drag away the child anywhere. And therefore, the court had really sued the hospital, and a compensation about 1 lakh was paid. Failure to attend surgery. This is one of the landmark cases, T.T. Thomas versus Elisir, which was decided again in the Supreme Court. A patient was admitted in the Kerala around in 74 with acute abdominal pain and with acute appendicitis, which required the operation. However, the patient repeatedly refused that I'm not going to get operated, I'm not going to get operated, and the operation tended to get delayed. But again, it was an emergency situation. The doctor who was looking after the patient was actually responsible to relieve the patient in a state of emergency, and the patient decision during a state of emergency where life and death is concerned really doesn't play any role. So the Supreme Court had held the doctor liable because he did not act appropriately in a state of emergency. Now, I was talking about the reasonable test. Now, what is the reasonable skill, or what is the reasonable man's test? This was, we have to look into the English law, because a lot of our laws are really derived from the English laws. And this is the test called the Bolam's test, which was decided somewhere around early 90s. This was a case where a boy was undergoing electroconvulsive therapy for a psychiatric problem. Now, during electroconvulsive therapy, you needed to give a muscle relaxant, which you may or you may not give muscle relaxant. If you give muscle relaxant, there are some chances of cardiac injury and death. And if you don't give muscle relaxant, then you may, am I exceeding my time? I can hear some talking, so sorry. So if you don't give muscle relaxant, there are chances of fracture. So the doctor who was doing ECT in the Bolam's case, he did not give any muscle relaxant, and as a result, the boy had sustained some fracture. The boy's mother had sued the hospital authority that you were negligent of your action. You did not give enough amount of relaxant which was supposed to give, and therefore you must pay me some compensation. Now it was decided in the House of Lords, because there were two modalities of treatment. You may give muscle relaxant, you may not give muscle relaxant, and then the court had adopted that a reasonable man may give this and may not give this, may adopt the reasonable doctor under these circumstances may adopt one practice or the other practice which was recognized by a body of professionals. This practice was recognized by the professionals, which were recognized by a body of doctors, that you may adopt any form of practice, but you have to justify this, and therefore the doctor nor neither the hospital was negligible of any action. The Bolam's test has been progressively adopted in the Indian laws as well, and it was first adopted sometime around late 90s in a case decided in the Bombay High Court, where a boy had sustained a fractured neck of femur, was brought into hospital, where the doctor had given him morphine because of pain. Given him some painkiller, taken him for X-ray, and then caused reduction of his fracture without giving any anesthesia. And after that, the boy had died because of pulmonary embolism from the fracture. It was held, the doctor was held responsible because this is not, the doctor had deviated from the ordinary practice of giving anesthesia. The doctor did not reduce the fracture without giving any anesthesia, and therefore the doctor was negligent of his action. Since this, then the Bolam's case has been very popular in making a stance about what is the reasonable practice, what exactly the law expects, that what should be the level of practice. Law doesn't want any extraordinary skill or extraordinary practice of an extraordinary person, but it just wants some ordinary or reasonable practice which most people would do, or which is recognized by a professional body. What about actual administration or treatment if an error of judgment comes in? Say, for example, the doctor is giving a treatment and he made a diagnosis correctly, but on giving the treatment, something or the other happens during the course of treatment. He will not really be negligent of his action, because if such a degree of care as a normally skillful member of the profession or a body of doctor, if they consider that this is also one of the procedures which can be adopted, then the doctor really doesn't become responsible for his responsible for any negligence. So when you think about error in judgment and what are the liabilities, you have to take the entire circumstances of the case. What sort of symptoms the patient had exhibited, what was the overall circumstance of the case, how much of time the doctor had devoted to examine the patient or deliberated upon the patient, whether the doctor had examined the patient properly, taken proper history of the patient, and whether the doctor had made any mistake while doing so. And even if he had done so, the practice which the doctor had adopted, will a body of professional persons or a body of professional doctors of the same line would have done the same thing or not? So these questions must be understood first before you really hold the doctor responsible. There is another maxim which is used, a Latin maxim called the res ispa loquitur. What does this mean? This means the thing speaks for itself. What is it? Now, a patient suffers from an injury, and it becomes very blatantly apparent that the negligent action or the patient's injury was because it wouldn't have happened until and unless the patient was exposed to such a degree of injury. So what happens that the injured patient must prove that the physician has breached his duty of care by failing to adhere to the set standards of care. And There are some examples of this. Say, for example, a doctor while operating leaves some object inside the body. Say, for example, very common occurrence is leaving a mop inside the abdomen, or if the wrong patient gets operated, if the wrong patient or the wrong medicine gets administered to the wrong person. So the patient wouldn't have suffered the injury until the mop was left inside. The patient wouldn't have suffered the injury until the wrong medication was administered to the patient. So it is blatantly apparent that the negligence has happened because of the direct action, and therefore the case of res ipsa loquitur comes in. If the patient or the defendant brings in a clause of res ipsa loquitur, it falls on the doctor or the hospital authority to prove that they haven't been negligent or there were some other casual effects which had led to the injury. It falls upon them. So a negligent action has happened. So what are the remedies which are available? Now, negligence can be brought under civil law as well as criminal law, and this can be done side by side as well. Under criminal law, if a complaint is launched under criminal law in the cases circumstances of death of a patient, you have a complaint for prosecution and it proceeds along with the criminal court according to the criminal rules. And under the civil law, you can bring suit for damages, that is tort law. You have to compensate suit for damages means you have to compensate the patient with some degree of monetary compensation. Suit for damages for breach of contract. A doctor-patient relationship is always a contractual duty, although there may not be any written contract, but again, there are non-written contract or there is some understanding between the doctor and the patient. Therefore, a breach of contract happens. And of course, you can complain the patient for a compensation under the Consumer Protection Act. The pro-regulatory bodies in India which look after such things or the complaints for doctor are, one is the Indian Medical Council Act 1956, and of course lately last year it has been replaced by the National Medical Commission 2020, Indian Dental Council Act which was formed even before the Medical Council Act 1948, Indian Medicine Central Council Act which looked after Ayurvedic, Unani, Siddha or the allied medicines 1970, and Homeopathic Central Council Act is totally different from this. The Consumer Protection Act. The Consumer Protection Act was 1986 in order to protect the consumer. Now, until up till 1995, medical profession was kept outside the purview of Consumer Protection Act. But 1995, there was a landmark decision by Supreme Court by the Indian Medical Association versus VP Samstha, and the medical profession was brought within the purview of or within the ambit of service. So what if there is a deficiency in service or any fault or imperfection or some inadequacy in the quality or the nature in performance of the service. Service means the action what the doctor does towards the patient or something or when the patient comes to the doctor pays for the service or pays for the action, and if there is some deficiency in this service, then obviously there is a breach of contract for this and the doctor can be held negligible for it. So any determination about deficiency of the service for the purpose of it may be applied by applying the same test as applying for damages for negligence. All medical services fall under the purview of Consumer Protection Act unless this service is completely free. Say, for example, patients going to state hospitals where the service is completely free, there is nothing at all charged for the patient, so the patient really cannot bring anything under the Consumer Protection Act. Any doctor or any organization which is charging the patient for some service, no matter how high is the charge, no matter how low is the charge, comes within the ambit of service. Say, for example, the hospital is run by a charitable trust, but the doctor gets paid for the trust and and the patient pays a nominal amount of registration charges. Then the patient is still liable to bring, if there is some shortage of service, then the patient is still liable to lodge a case with the Consumer Protection Act. So who is a consumer? A consumer is someone who buys any goods or a user of goods or uses the goods and service in order to earn a liability. So anywhere where there is a breach in this service or this service is not provided adequately, you can bring in a complaint under the Consumer Protection Act. So who can file a complaint? A consumer or the patient in these cases. Any recognized consumer association or a patient association can also launch a complaint, or a central or a state government can launch a complaint. Where are the forums these complaints can be lodged? Now, there are some distinct forums where the consumer protection, where the consumer action can be launched, and these are judged according to the monetary compensation that a case owns. You can launch a district in the district consumer forum if it is less than 20 lakh rupees. These laws have come after the National Medical Commission was formed, and since last year, these are the latest rulings. In the district forum, it can be launched if it is less than 20 lakh. If the state commission, if it is more than 20 lakh but less than 1 crore, and in the national commission, if the compensation claim is more than 1 crore. And there are a lot of calculations which can be made according to the how much of compensation can be claimed, which depends upon the earning of the patient, how much the patient was earning, what was the age of the patient, what sort of livelihood he was leading, what is the future projected earning for the patient. These are the, and plus the mental ability, plus the mental stress and strain, the agony that the patient undergoes. There are a lot of things which has to be calculated while you are calculating the compensation. Now you have launched a case against the doctor. Now the doctor will also have some ground for pleading in the consumer forum. So there are lots of laws for the doctor as well, for which the doctor can stand or defend his case. So if according the Indian Penal Code, section 80 says that if anything happens by accident or misfortune, there was no intention or knowledge for the doctor that the act was lawful, he can really plead on those grounds. The doctor can say that is done with the knowledge that is likely, if the doctor know that if anything is done with the knowledge that is likely to cause the harm, but without any intention, but was done in good faith and avoiding other damages to the person or property, then obviously the doctor cannot be held responsible. And according to section 88, no one can be held liable for an act which was done in good faith for the benefit of the patient, because the doctor did not intend to harm the patient, and all the risks involved in the patient's has already been explained, and a proper consent has been taken for this. If I have time, I will run through a few landmark interesting cases, Supreme Court judgment. Now, the landmark judgment of our times is for the highest amount of compensation which is paid. In fact, this is the global highest amount compensation judgment. Till date is Dr. Kunal Saha versus Shukumar Mukherjee and others, which is famously known as Anuradha Saha case. Everyone from Kolkata knows about the history of this case very well. Lady was suffering from some sort of allergy, got admitted in the hospital, was treated with some medication. Patient developed side effects of the medication, and the group of doctors who were treating the case were sued. Case ran on for a long period of time. Patient's husband, Dr. Kuna, is a doctor, and then they had calculated the amount of the compensation to be given, and it amounted up to 6.08 crore for the individual doctor, as well as there were some other amounts to be contributed to the hospital as well. This is one of the landmark global cases for the highest amount of compensation which is awarded to a patient who has been negligently treated. Let me go to Jacob Matthews versus State of Punjab, where Supreme Court has held that sometimes the doctor needs to make a very, very difficult choice. Say, for example, the patient comes in extremely unwell condition. The patient, say, for example, a bad road traffic accident where the patient may die if he is not operated, and may die if he is not operated, he will die, and even if he is operated, there are high chances of mortality. But the patient's party gives consent to the doctor to go ahead with the operation, and some mishap happens, and then the patient's party go back and then sue the doctor. Then obviously there will be some decisions in the court. The court will look into the evidences and say that looking upon the circumstantial evidences, the doctor cannot be sued. There is this case of Juggan Khan versus State of Madhya Pradesh, where the person was a homeopathic medical practitioner. He had given some advertisement that he was treating or making everything better with guinea worm treatment, and accordingly, a lady from rural Madhya Pradesh went to this doctor, and this homeopathic practitioner had given him this medicine, and then she started feeling restless because of some allergic reaction. He did give him some antidote as well, but the patient succumbed, and then this doctor was held negligent for a murder under section 302 of the Indian Penal Code. Then there was another case, again this happened in Madhya Pradesh, Poonam Verma versus Ashwin Patel. This person had a homeopathic, was trained in homeopathy, and this lady went to her for some medical termination of pregnancy, and she administered him some drug, and this lady had undergone some reactions and died ultimately. This person, although he was administering the drugs to a number of persons, but he did not have appropriate training in the system of allopathic system of medication, and therefore he was amounted to medical negligence because he was done that. There was another case. This is again a landmark case of Spring Meadows Hospital versus another Harjol Aluwalia. Harjol Aluwalia was a child who was suffering from typhoid fever and was admitted to a hospital in the Spring Meadows Hospital. A nurse had given an injection to the child and then he collapsed. And then the hospital had taken all measures to recover the child. He was transferred to AIMS, and then the child could not be recovered and he succumbed. The doctors were informed about the critical condition of the doctors did inform the parents about the critical condition of the child, that they held that the child had a cardiac arrest because of the overdose of injection to the doctor. And obviously the nurse who had injected the child was held responsible for this. But again, the nurse is not held sued, but the hospital authority and the doctor bears a responsibility for this. And this is something which is called as a vicarious responsibility. The case I was talking about of the fractured neck femur, and where the Bolam's evidence was brought into Indian law for the first time, was Lakshman Balakrishna Joshi versus Trimbak Bapu Godbole in 1969, and where the person had a fractured neck of femur, and it was reduced without giving anesthesia, and the person died because of pulmonary embolism, and the doctor was held negligent because of he did not follow the proper practice. This is my last case that I'm going to show you. Samira Kohli versus Prabha Manchanda, which was decided in 2008. This is again a landmark case. Dr. Samira, she's a 44-year-old married lady. She went to her gynecologist because of some menstrual problems. A gynecologist suggested that she undergo some laparoscopic test, and accordingly she got admitted to the hospital. And on her admission form, out of the consent form, they had consented for a diagnostic laparoscopy, and maybe a laparotomy may be needed. Now, while the doctor was doing the laparoscopy, she felt that the ovaries were completely diseased. Now, this lady was a spinster. She was 44-year-old, but then her marriage was contemplated. She was engaged to a person and then was about to get married the year after. Now, while doing the laparotomy, the doctor felt that her ovaries were diseased and the uterus had got a large fibroid which required operation. She was under anesthesia during that time. So the doctor's assistant went outside the operation theater to consent from the mother of the patient that this is the condition, what should we do? Should we go ahead and do a hysterectomy and oophorectomy? And the mother gave a consent that yes, if that can save this lady was suffering from endometriosis, beg your pardon. She was suffering from endometriosis, and obviously one of the treatments for endometriosis is oophorectomy, and sometimes you do have to do hysterectomy as well. So the mother consented for this, and later on, the patient sued the doctor that the doctor had removed my uterus, ovaries, fallopian tubes, and therefore fully jeopardized her future married life, her chances of bearing a child. And this was done without taking a proper consent from the patient. The consent was taken from the mother, but whereas the patient being an adult, responsible patient, the consent should have taken from this, and therefore this was not a real consent which was taken from the patient, and the doctor was sued for this, and a huge compensation was taken. So as a medical profession, unlike other professions in the world, globally, medical profession is the only profession we are bound by ethics. We have got some form of extra responsibility which we owe to our customers, that is our patient. Say, for example, an engineer builds a big bridge, the bridge breaks down. The engineer doesn't have the responsibility, doesn't take upon the responsibility that the bridge is broken because of my bad engineering model. Say, for example, a lawyer loses a case, but the lawyer's client doesn't sue the lawyer for losing the case. It's taken for granted that you may win or you may not win. But a doctor is bound by ethics, and the patient expects some added or extra responsibility when the patient goes to the doctor. And because of this added responsibility that the doctor shoulders, all these emotional things comes in, and then the cases of medical negligence does happen. I'm not saying that medical negligence doesn't happen, but many a times it's seen that the doctor was not negligent at all, and yet a lot of cases are being brought against the doctor. Sometimes things are again out of hand of the doctor. Say, for example, under pressing circumstances, like in our country, a surgeon operates in small nursing home because of financial strain of the patient, and that small nursing home doesn't offer adequate instruments. Say you are doing an operation and you have you have to really sometimes you have cautery machine, and the cautery machine doesn't have the adequate sharpening, adequately sharp enough to cut the tissue, and some injury happens, but the doctor is held responsible because of the faulty tools. The patient holds the doctor responsible, not the nursing home. Another important concern is that we are brought within the ambit of consumer from the Consumer Protection Act. So we are offering a service which is ethics bound, and yet we are treated like we are giving you some sort of consumer service. People are losing faith because of some serious medical negligence issue. Again, another cause of losing faith is because we don't communicate with our customers very properly. We need to really have some serious introspection in this. And also, medical ethics needs to be reformed and developed so as to serve complete righteousness. Now, as of the final position of the law is that we need to have a proper rules to be framed by the government in consultation with the National Medical Commission. A private complaint should not be really entertained by the magistrate unless prima facie evidence before the court in the form of negligence on the part of the doctor. And the investigating office also must require a second opinion from another competent doctor who will really look into the case properly and guide. Thank you very much for listening. I stop sharing now.
Thank you, Dr. Mukherjee, for covering this extensive topic quite nicely and taking us through the nuances of the this topic. However, I think I can just have only two comments generally from your topic, that, error of judgment may not necessarily amount to negligence. And similarly, genuine mistakes can also be overlooked by the court of law. However, there are a lot of gray areas, as you have mentioned, and I think there should be extensive discussion on this topic. It takes a whole day, I suppose, if not the whole week, to discuss all the aspects of this topic. So since we have run out of time, I don't think we will have any discussion or questions at this point of time. However, the delegates may leave the questions in the chat box, and in the end of the discussion, I think we can address the issue. Dr.
Thank
Lee,
you very much for that. I'll take your leave because I've got somewhere else to attend. And if you have any questions, put in the chat box, and I'll request Debashish to forward me the questions, and I shall forward the answers.
Yeah, that would be very nice. Thank you.
I'll talk to you regarding, I've got quite a few questions on these issues, but I'll talk to you later on. Thank you.
There's one point I'd like to raise, which you can elaborate later, is informed consent, which I think in many of the hospitals...
that can be a completely different topic. Informed consent. What do you mean by informed consent?
Yeah, well,
that's totally one single topic to be discussed.
That's right. Informed consent is something which is inadequately done in our hospitals and institutions. And one other thing, the patient's relatives are given importance than the patient himself or herself. I don't understand this. If I have a problem, I should be consenting if I am conscious. But here, in most of the hospitals, they ask the spouse or relative to sign the consent form. Whatever the form of the question, their informed consent is, and that also is a fallacious information. So there is a lot of fallacy in this area, which should be sorted out very soon for all of us, for the benefit of all of us, I mean.
Thank you, Dr. I think we should have a proper discussion, a day-long discussion on this topic, I suppose. It's a very short time to cover it.
Ashok Kaushik has raised his hand. I think he has...
I think for the shortage of time, let us not have any questions discussed. There are many questions which can come up right now. Let us move on to the next part of the topic.
Thank you very much. Thank you. I'll take
Thank you.
All right. So the next topic basically we're going to talk about is about the nephrotic syndrome in the pediatric age group. And the speaker for the session is Dr. Shushmita Banerjee, and the chairperson is Dr. Bijan Bhattacharya.
Good evening. Welcome to this session. I think Dr. Shushmita Banerjee has already been introduced, and I think she's probably the first pediatric nephrologist in Kolkata, if I'm not wrong. And she's going to talk on a very important problem, that is the nephrotic syndrome in children, because it is common, one of the commonest causes of ill health, infection, all the other complications. And the thing is that it is a disease of relapse and remission. And the problem is that the recurrent episodes of remission of relapse, and obviously the doctor is faced with unsatisfied parents, and so it is really a problem. With a steroid and other immunosuppressive drugs also there is frequent relapse. So without wasting much time, I would request Dr. Susmita Banerjee to give her talk, and especially I would be interested in how to prevent the frequent relapses of this disease. I'm sure we'll learn a lot of things from her. Dr. Susmita Banerjee.
Before Shushmita starts, it is my proud privilege to see Shushmita in this platform. I met her for the first time when I was doing my house job at medical college, and she was my first intern. I don't know whether she remembers it right now. I was working in the unit of Professor Ranabir Bose, and she was my intern, one of my first interns who worked with me. So over to you, Shushmita.
Thank you so much, Dr. Bhattacharya and Shujoy. Can I just ask if you can see my slide in the proper?
Yes, you're visible. You're visible.
In the proper slide share mode. Okay. So I will start by thanking Dr. Icrcpi Rai and Dr. Monojit Mukhopadhyay for asking me to present at this Royal College of Physicians Indian Chapter webinar. I know that the majority of the audience are not pediatricians and also are not nephrologists. So I'm going to give you a very sort of a general overview about the topic of nephrotic syndrome in the pediatric age group. And the plan is to focus on the differences between children and adults, because for a very long time in Kolkata and in many parts of India, there were no pediatric nephrologists, and adult nephrologists were treating children. And there was a tendency to treat children very similar to what adult management was. So I want to show you how children with nephrotic syndrome are so very different from adults, and how the management is, again, because of this reason, so very different. I also want to talk about why pediatric nephrotic syndrome is such an important topic for us pediatricians, briefly about etiology and pathology, clinical features and different types. And as Dr. Bhattacharya said, you have very simple types of nephrotic syndrome, but you also have really, really difficult types which relapse and go on relapsing for years and years and years. So I will focus a little bit with some case studies on patients who have difficult nephrotic syndrome, and of course talk about evidence-based protocols of management. So we start with why are children not little adults? Why can we not treat children with protocols that are used in adults? So the main reason is that the majority of children have minimal change disease. Actually, between 80 to 90%. And secondary causes of this minimal change disease are very rare. So the majority have idiopathic nephrotic syndrome secondary to minimal change disease. In children, we take steroid response to be an indication that the underlying disease is minimal change in nature. So we do not do a renal biopsy at the start. We only do renal biopsy if there are some odd or atypical features, or if the child does not respond to steroids. Children with minimal change disease are extremely steroid sensitive in children. Exquisitely steroid sensitive is the terminology that is used, and the majority will respond within 2 to 4 weeks of starting the standard doses of steroids, while a few outliers will take a little bit longer, but certainly 95% will respond within 8 weeks. Now compare that to adult nephrotic syndrome. Minimal change disease is rare, only 15% or less, and the majority of adults presenting with nephrotic syndrome will have membranous nephropathy, FSGS, or other primary diseases like SLE, etc. Even if they do have minimal change disease, then the underlying cause is likely, such as an infection, such as hepatitis B, a lymphoproliferative disease, some drugs, etc. So 50% of even this minimal change disease is secondary. And because of all these reasons, they need a very intensive workup, including a renal biopsy very early on, because we need to know what the etiological diagnosis is so as to manage them effectively. When other etiologies have been excluded and we have confirmed idiopathic minimal change disease in adults, then prolonged courses of steroids are usually required, and up to 16 weeks is often required to gain an effective response. Next, in adults, complications like hypertension, hematuria, acute kidney injury are more common, and these are actually harbingers of prolonged courses and poor outcomes. So many of these patients with these features at presentation will develop chronic kidney disease. In contrast, in children, these complications are rarer, but children often have infections and hypovolemia at presentation. If they are picked up rapidly and treated effectively, these are reversible and usually do not affect the long-term outcome. Both adults and children do better if they have minimal change disease in comparison to non-minimal change diseases. But pediatric patients in particular, even if they have frequent relapses or steroid dependence, they have the majority who are steroid sensitive will have ultimate resolution. So we can expect a good outcome in the majority of pediatric patients. There are a large number of RCTs in pediatric nephrotic syndrome. Relatively, there are fewer RCTs in adult nephrotic syndrome, probably because minimal change disease is rare and RCTs have to be segregated according to the underlying disease. So pediatric nephrotic syndrome is much, much more protocol-based than adult nephrotic syndrome. And very standard guidelines and protocols are available for the treatment. And most of these guidelines are international, and all of us globally treat these patients in a similar manner. In contrast, in adults, as I have said, that the management depends on what the underlying etiology is. It also depends on patient comorbidities like obesity, hypertension, diabetes mellitus, etc. So as you can see, there's a huge number of differences between pediatric nephrotic syndrome and adult nephrotic syndrome, so much so that it is thought that pediatric nephrotic syndrome is a completely different disease compared to adult minimal change disease, and therefore pediatric patients merit a completely different workup and management protocol. Why is pediatric nephrotic syndrome common? If you look at overall incidence, it doesn't look like a very common disease. But we all know that it is one of the commonest conditions that present to pediatric nephrologists, particularly in Southeast Asia. Out of the patients presenting with nephrotic syndrome, more than half will have a chronic, prolonged relapsing course. And unfortunately, this relapsing course will occur at a period when the children are growing, they are supposed to be learning, attending school, having interactions with peers. And the recurrent illness, school disturbance, disturbances in social interactions give rise to a lot of short-term morbidities. And also we get a lot of long-term morbidities, which can be physical, that is obesity, short stature, cataracts, glaucoma. And again, what is often forgotten that it can lead to psychological morbidities as well. However, we know that almost 90% will resolve by adulthood. So the real impetus is in trying to very effectively treat these patients so that they can have as near normal childhood as possible and evolve into a normal, intact adulthood. Let's look at etiology. The vast majority of patients have idiopathic nephrotic syndrome, that is, no specific cause can be found. A very small number, less than 5%, will have one of these other underlying causes. Several genetic causes have been discovered, and if you look at the list of genes, it goes into 3 to 4 pages long currently, and newer genes are being discovered all the time. Most of the genetic nephrotic syndromes are steroid resistant, and it has now become part of the course that steroid resistant nephrotic syndrome patients should have a genetic test done. These are some of the common genes that are discovered in such patients, and all of these genes are associated with maintaining the intactness of the glomerular filtration barrier. We sometimes find congenital nephrotic syndrome due to infections such as intrauterine infections such as toxoplasma, rubella, congenital cytomegalovirus, etc. And rarely, as in adults, there may be nephrotic syndrome secondary to infections such as malaria, hepatitis B, HIV, drugs, malignancies, particularly lymphomas. When we talk about idiopathic nephrotic syndrome, it means that we have excluded all these other primary glomerulopathies such as SLE, IgA nephropathy, etc. And only then we can call it idiopathic nephrotic syndrome. Whatever the cause of the underlying disease is, whether it be idiopathic or one of the causes that I have listed previously, the final common pathway seems to be a disruption of the glomerular filtration barrier. And here you can see an electron microscopy of this filtration barrier. This is the glomerular capillary loop, the podocyte foot processes, and this is normal, where you can see that the slit processes are intact. This is the normal glomerular filtration barrier, whereas in nephrotic syndrome, these foot processes are fused, and this gives rise to the massive proteinuria that is detected in nephrotic syndrome. So focusing now on idiopathic nephrotic syndrome, the diagnostic criteria will be familiar to most of us. Most of the patients will present with edema. On examination, we detect nephrotic range proteinuria, and in children, the criteria is of nephrotic range proteinuria is more than 40 milligram per meter squared per hour on a timed sample, or more than 2 plus on dipstick, or a spot protein creatinine ratio being more than 2 milligram per milligram. This is usually associated with hypoalbuminemia and hyperlipidemia. The majority of the patients will have a normal creatinine or normal blood pressure. They may have minimal microscopic hematuria, and no primary cause should be detected. Sometimes patients will present with a complication such as infection, hypovolemia leading to AKI or thrombosis, or PRES, but these are relatively rarer, and we will talk about them in the subsequent slides. So no primary cause should be detected. Patients who have features similar to these, rashes, joint problems, macroscopic hematuриas, extrarenal symptoms, will have other causes of nephrotic syndrome, and we are not going to talk about this group today. So further, we are only talking about the idiopathic nephrotic syndrome of children. I have said right at the beginning that the indications of kidney biopsy are different from that in adults. We do kidney biopsies at presentation of nephrotic syndrome if the age is less than 1 year, because in this age group, the genetic causes are more likely. A relative indication for a renal biopsy is age over 12 years, or 12 years in whom more non-MCD cases are more likely, such as membranous, FSGS, etc. But this is a relative indication, and often we will give steroids even in over 12-year patients to see if they respond or not, and do a biopsy only if they do not respond. If there are atypical features like significant macroscopic hematuria, hypertension, low C3, if there is low GFR, which is unrelated to reversible hypovolemia, or slide extra renal features suggesting secondary LS. So these are the indications of a kidney biopsy at presentation. Subsequent kidney biopsy during the course of the illness may be done at steroid resistance. That is, we have given steroids for 4 to 6 weeks and the child has not responded, or in steroid dependent patients before starting or when we are treating with prolonged doses of CNIs, that is tacrolimus or cyclosporin, because these drugs are known to be nephrotoxic. Management of pediatric nephrotic syndrome involves specific regimes, immunosuppressives and steroids, and several supportive regimes, which I will again talk about later. So going first to specific treatment, I mentioned that the majority of the protocols and guidelines are evidence-based, and there are a large number of RCTs available looking at both corticosteroid treatment and other immunosuppressive treatment in patients with pediatric nephrotic syndrome. There are a huge number of guidelines available. Almost every country, every major country has developed their own guidelines. But since all of us are depending on the same RCTs for developing these guidelines, there is actually very little difference between all these guidelines. And that is why I mentioned that internationally, this disease is treated extremely similarly. And now we have the International Pediatric Nephrology Association, which is trying to combine all these guidelines into one that everyone can use. The ISPN, that is the Indian Society of Pediatric Nephrology, first published nephrotic syndrome guidelines in 2001 and have been regularly updating them. The 2021 guideline has been accepted for publication in the Indian Pediatrics Journal. So the latest version will be out very soon. And as I have said, it is really, the guideline is not particularly different from all the other international guidelines. In the first episode of pediatric nephrotic syndrome, patients are treated with 2 milligram per kg per day of prednisolone or 60 milligram per meter squared of surface area for between 4 to 6 weeks, followed by 1.5 milligram per kg per alternate day for again 4 to 6 weeks. And the studies show that a total therapy of 8 weeks to 12 weeks is sufficient for management, and prolonging the treatment further does not do much good. It is also really important to counsel regarding monitoring urine protein and recording the results. So the patients can use the heuristics which is available or the heat method. The heat method tends to be a bit subjective, and more patients are becoming willing to use the heuristics for maintaining their monitoring diaries. For diet, we generally do not restrict particularly, but we say no added salt in an attempt to reduce salt and water retention and reduce edema. The patient should have completely normal activities. So bed rest, restriction of activities is really contraindicated because, as you know, these patients have a risk of having thromboembolic complications. The commonest complications are infection and hypovolemia, and the families need to be alerted to early symptoms and signs of these, and they should know that they should attend for very early if such signs and symptoms occur. Vaccination is a very major part of producing protection against infections in children. Vaccinations are usually avoided when the children are on high-dose immunosuppressants and steroids, and appropriate vaccination advice also needs to be given. While we avoid vaccination during immunosuppressive therapy, we do try to vaccinate, to update vaccinations and to time the vaccinations according to when the patient is off steroids or on minimal low-dose steroids. Now, with this initial treatment of the first episode, the majority of patients will go into remission by 4 to 6 weeks. However, if there is no response within 6 weeks to the first course of 2 milligram per kg per day prednisolone, this is termed as steroid resistance, and the child needs a renal biopsy and then further management depending on the result of the renal biopsy. If the child does respond, then alternate day steroids is started after 6 weeks, and therapy is continued for a total of 8 to 12 weeks, as I have mentioned. However, even when patients go into remission, a large number will relapse subsequently. Patients who have infrequent relapses, that is less than 3 relapses per year, are treated with short courses of prednisolone. However, the problem is with patients who relapse more frequently, that is have 2 or more relapses in 6 months, 4 or more relapses in 12 months. These patients are termed as frequent relapsers. Or even more difficult are patients who will relapse while still on steroids or within 14 days of discontinuation, and they are called as steroid-dependent patients. The ISBN guidelines say that after the first episode, which I have mentioned, after completing treatment, if the patient has infrequent relapses, we treat with prednisolone 2 mg per kg per day until remission, and then 1.5 mg per kg every alternate day for 4 weeks. If patients have frequent relapses or steroid dependent, we try to maintain them on the lowest possible dose of alternate day prednisolone, which will maintain remission. However, even with this low dose, sometimes patients will end up really pushing on it. And in such patients, steroid-sparing agents need to be used. And these are some of the options which I will discuss again later. And as I've already mentioned, steroid-resistant patients need a renal biopsy and then subsequent treatment. Our experience in Kolkata, out of 500 sequential nephrotic syndrome patients, you can see we had only 3 patients with congenital nephrotic syndrome and 14 with steroid-resistant nephrotic syndrome. So the vast majority had steroid-sensitive nephrotic syndrome. Out of these patients, 50% had frequent relapses or steroid dependent. So this is very similar to international experience. The majority of our patients presented between 1 to 4 years of age. And you can see that steroid dependence and frequent relapses were more common in the younger patients. What is most useful is this slide, I think, because a patient who is relapsing frequently, the real question that the parents ask all the time is, when will these relapses stop? And our patients indicated, our follow-up studies indicated that 50% of patients will stop relapsing by 5 years of age. So that's a really useful statistic to have to counsel patients, that there is a 50% chance that your child will stop relapsing by 5 years. However, younger patients tend to continue relapsing for a longer period of time. So we have seen that a lot of patients will do well with the guidelines that I have shown you. Many will have will have infrequent relapses. 50% will have infrequent relapses. But the difficulty is with patients who have either steroid-dependent, frequently relapsing nephrotic syndrome, or with patients who have steroid-resistant nephrotic syndrome. And I have just included 2 case studies to show you that despite the majority of patients having relatively easy to treat courses, how some patients can be really difficult to treat. So the first patient is a child who had steroid-dependent nephrotic syndrome from 2 years of age. The issues with him was severe steroid dependence. So every time you actually went from daily to alternate day steroids, he would relapse. He had multiple infections and required several hospital admissions. In one hospital admission, he had a prolonged relapse with sepsis, needed inotropes, needed peritoneal dialysis for AKI, and we really thought we were going to lose him at that stage. However, he recovered from that, but he was Cushingioid, obese, short, had bilateral cataracts, he had low bone mineral density. So you can see he had a lot of the complications of nephrotic syndrome. He also had a lot of the complications of the treatment of nephrotic syndrome. Now, what are the options we have with such patients? We do not want to keep giving these patients steroids in the hope that they will maintain remission, particularly when their steroid threshold dose is so high and it is causing such great steroid toxicity. So these are all the steroid-sparing agents that are available to us. The RCTs do not really show that any one of them works better than any of the others. The adult nephrologists are usually using drugs like tacrolimus. However, in pediatrics, tacrolimus and cyclosporin, the CNIs. However, in pediatrics, where this condition is expected to last for years and years, we try to hold off the CNIs for as long as possible, unless we really have to use them because of their underlying nephrotoxicity and other adverse effects which are listed here. So we would generally start with the drugs that have the lowest side effects. And the general feeling is that we start with levamisole because it has the fewest adverse effects. If this doesn't work, we go on to cyclophosphamide, then MMF, mycophenolate mofetil, and only when these don't work, we try the CNIs. Fortunately, we nowadays have another drug, rituximab. So if nothing else has worked, rituximab is resorted to, and almost 60% of patients will improve in their steroid dependency after getting rituximab. So a sequential therapy trying to avoid long-term adverse effects is what is usually resorted to in such difficult patients. Now, the second patient is steroid-resistant nephrotic syndrome from 1.5 years of age. Again, he required multiple medications. He was dependent on CNI, on cyclosporin, which put him in a partial remission state, but he did not go into full remission even with the CNI. He needed 3 diuretics to maintain him edema-free. After prolonged use of CNI for years, we tried a few times to change him to rituximab, to mycophenolate, but every time he was admitted with hypovolemia, diarrhea, anasarca, and major relapses. Over the years, he developed hypertension, hyperlipidemia, and the most troubling problem eventually was a recurrent pleural effusion, which recurred every time that it was drained. So steroid-resistant nephrotic syndrome, just a few words. No response to steroids after 6 weeks is what is said in the latest ISPN guideline. We nowadays exclude underlying genetic mutations because if there are genetic mutations, then it's pointless to treat these patients with huge doses of immunosuppression because nothing will work. If we do not treat patients, then eventually ESKD occurs and a lot of other complications. The majority of patients with steroid-resistant nephrotic syndrome may still have minimal change disease, but many will have FSGS, mesangial proliferative glomerulonephritis, and then these are some of the rarer causes that may emerge. This is a slide of a child with FSGS. You can see the sclerotic patch over here within the glomerulus. The RCTs indicate that the calcineurin inhibitors, cyclosporin and tacrolimus, are the best bets in treating these patients. And many patients, even if they are steroid resistant, may be CNI responsive. Now, patients with difficult nephrotic syndrome or patients who ignore a relapse and come very late for treatment often develop very major complications. So edema, of course, is one of the components of nephrotic syndrome. And if not treated in time, or if they are steroid resistant, then this can be really gross and cause a lot of problems with mobility and a lot of other issues. Hypovolemia and infection, I have already talked about. Hypovolemia can give rise to acute kidney injury, thrombotic complications, etc. Patients may have hypertension. This is a patient with a deep venous thrombosis. This is a patient with spontaneous bacterial peritonitis, which is the commonest infective complication. And this is a child with posterior reversible encephalopathy. So these are all complications that these difficult patients or patients that are non-compliant and come for treatment late can develop. So vaccines to protect against infections are really important. And most important is family education, regular monitoring, and repeatedly telling the patient that come immediately if there is a relapse. Because if we can treat a relapse very early, then such complications should not occur. Um, the severity of nephrotic syndrome also has an impact, psychosocial impact on families, which often is not taken into account. And one of our PGTs did this study on the psychosocial effect of pediatric nephrotic syndrome on families and found that a lot of patients were actually spending much more than their income on immunosuppressive drugs, on travel, repeated travel to the hospital, etc. And the depression scores were higher both in children and in parents and in the caregivers, particularly in patients with difficult disease. We also produce a lot of iatrogenic complications because we have to treat these patients with different toxic medications. You can see a Cushingite child, a child with benign intracranial hypertension, gingival hyperplasia in a child on cyclosporin, and so many other complications need to be monitored for and managed. What happened to the two patients that I told you about? The first patient is now 11 years. You will remember he started off at 2 years. We updated his vaccinations in an attempt to reduce his infections. We stressed on home monitoring and early attendance if relapse or if infection. The eyes were looked at, growth, blood pressure monitoring and treatment, vitamin D treatment was given. I told you cyclophosphamide, MMF, even MMF and CNI did not produce good long-term effect. He had a renal biopsy eventually after being on CNI for some period, and he had minimal change disease, fortunately. And what really worked with him was rituximab. He has had 4 doses altogether, and he is now in remission for more than a year now. And this is this child now who is off all treatment, maintaining remission. So even with such a difficult course, you can get a good outcome. The second patient who I told you required multiple drugs to maintain edema-free status. He was managed with dietary intervention for hypolipidemia, atorvastatin. He had a pleurodesis for recurrent pleural effusions. He was on enalapril, antihypertensives. He had genetics tests which did not reveal any mutations. He had 2 biopsies, both of which showed progressive FSGS. Fortunately, he still maintains a normal creatinine. And with all this therapy, he is looking very much better than previously, goes to school, and has a relatively good quality of life. So to summarize, this can be a difficult disease, but not in all. You can see this young mother, she had nephrotic syndrome in childhood, but has grown and now has a family of her own and no further relapses for many years. This child is 18 years old now, goes to college and brought his younger brother for some minor illness. And he had very, very severe nephrotic syndrome in childhood. But all stories are not so good. And this is a child who had steroid-resistant nephrotic syndrome, who went into end-stage renal disease despite all interventions, all drugs. She was in peritoneal dialysis for several years and then on hemodialysis. And in 2017, she had a kidney transplant. Her mother was the donor, and she is doing brilliantly since. All these photographs are with the permission of the patients, but you can see that even with difficult cases, outcome can be good. I will emphasize again on protocol-based specific treatment. we should all really speak the same language with these patients, and the same messages, the same drug doses, the same sequence of therapy should be used. A closed interaction between patients, parents, pediatric nephrology is essential to get good outcome, particularly in the difficult patients. Education to monitor urine protein, watch out for danger signals, pick up and treat infections, relapses, hypovolemia early. All these are very important. Vaccinations are important. Regular monitoring, I have already mentioned. And we know that there are continuous advances in knowledge with newer genetics, newer drugs being made available all the time. This is a collage made by the first patient with steroid-dependent nephrotic syndrome that I presented. And Dr. Rai asked me to talk about guidelines for adults and children. And so you have these international KDIGO guidelines, which were initially published in 2012. And then there is an updated draft, which will be published, I think, sometime this year, which covers both pediatric and adult nephrotic syndrome. And you can see the real difference in the diseases and their protocols of management. In pediatric steroid-sensitive and steroid-resistant nephrotic syndrome, you have very current guidelines, both by the Indian Society of Pediatric Nephrology and by the International Pediatric Nephrology Association. So I think with all these guidelines, it has made our task relatively easier to have this background knowledge and this guidance for treating our patients effectively. Thank you.
Thank you, Dr. Banerjee, for your nice talk. Within such a short period, and you have mentioned all the problems usually with the nephrotic syndrome in children. As we are short of time, I can't ask let others ask you any question. But I have got only a small comment and you can say question. In textbooks, it is mentioned that about 50% of the children during the first attack of nephrotic syndrome, there is spontaneous remission. But I have hardly ever seen any spontaneous remission, and I really doubt it. So what is your opinion?
Dr. Bhattacharya, we do see a few patients who go into spontaneous remission, but invariably they will relapse sometime later. So if patients come to us sometimes saying, I had edema, and then I test them and there is no proteinuria, I will always tell them to buy a heuristics and to check urine protein, because I am sure they will have another relapse very soon. So at least then they know that they should what to monitor and come in very early if there is a relapse and not wait to get too puffy.
Okay, thank you so much. So I'll close this session.
Can you
Dr. Banerjee, just
stop sharing this?
Yeah, Dr. Banerjee, just a couple of questions for you.
Sure.
Yeah, basically, first of all, I mean, when you're putting patients on steroids, as you mentioned, for 6 weeks plus 6 weeks in the steroid-sensitive nephrotic syndrome, how difficult do you find it to win them off the steroids? And what is the degree of, say, an adrenal suppression that you notice in such patients? That's the first question. And secondly, with calcineurin inhibitors, for example, in following post-transplant patients, there has been an increased incidence of what is known as a new onset diabetes or post-transplant diabetes. So any experience on that, on these two issues?
Sure. So weaning steroids, there are multiple studies really that show you that you don't need to wean steroids in idiopathic pediatric nephrotic syndrome, in the sense that you give them 6 weeks of daily steroids followed by 6 weeks of alternate steroids, and then you stopped abruptly. And there is sufficient evidence that that does not cause adrenal suppression in any way. But the rider is that if such patients become critically ill, then they have to be given a stress dose of hydrocortisone for over a year. So this effect during a critical illness over the next year, this effect will need you to give them stress dose hydrocortisone. That's the first question. Second question about diabetes with tacrolimus. We do see it. The second child who was transplanted developed diabetes with tacrolimus, and we had to reduce the tacrolimus doses. We do see it in steroids-dependent nephrotic syndrome who are treated with tacrolimus as well. Not so much with steroids alone. We would, in such patients try, because in steroid dependent nephrotic syndrome, you have a lot of other options. So we would try to minimize the tacrolimus dose, maybe switch over to one of the other medications. But if we have to give them tacrolimus, then we would treat the diabetes alongside. I hope that answers your question.
Yeah. Thank you.
Thank you.
I'm sorry,
Right,
I
so
can't find the tab to stop present. Okay, it's done, I think. Okay, thank you.
Right. So with that, we move on to the last part of today's discussion today. And this is about a topic which is very close to our heart, that is GLP-1 receptor analog-based incretin therapy. And to talk about it is we have Dr. Monojit Ketan Mukhopadhyay, who I think probably doesn't need any introduction, and also the chairperson, Dr. Demallo Shannal, who also doesn't need any introduction. This session is sponsored by Novo Nordisk, the Victoza arm. Dr. Shannal, as we all know, is a consultant endocrinologist at Rabindranath Tagore International Institute of Cardiac Sciences, and he is also attached with the KPC Medical College, I think in the role of professor of diabetes and endocrinology. He has got numerous publications and presentations and is quite an academically active endocrinologist in our fraternity. The speaker, Dr. Monojit Ketan Mukhopadhyay, is basically the consultant endocrinologist at Amri Hospital, Dhakuria, and EDF Hospital. He's a faculty at various national and international forums. He's an avid researcher and involved in a number of phase 3 and phase 4 clinical trials. He's a faculty of the prestigious CCE-BDM course run by the Public Health Foundation of India. He's physicians on diabetes in India, and he has contributed. I think it's
to train physicians.
Right. So this has gone into the next slide. Okay.
Yeah.
He has contributed several chapters to books and for diabetes for physicians and patients. So without wasting much words, over to Dr. Demallo Shannal to run the session and invite Dr. Mukhopadhyay.
Thank you, Sujata, and thank you for the kind words and introduction as well. Well, just a brief introduction to the GLP-1 topic, because some of you may not be acquainted with that regularly, because glucagon, GLP-1, or what is known as glucagon-like peptides, these are basically the incretin hormones which are secreted from the intestine, and this actually have really revolutionized, really changed our management with regards to diabetes, and it has been a significant advance in our management, especially with regards to its insulin-dependent, glucose-dependent insulin secretion, and also its effect on the alpha cell, decreasing the glucagon. And at the same time, it decreases the risk of hypoglycemia by increasing glucagon secretion during the time of hypoglycemia. It has additional benefit in terms of decreasing gastric emptying as well as decreasing appetite, and that helps in reducing weight as well. And overall, it also has anti-inflammatory effect as well. So because of that, we have quite a number of studies showing favorable cardiovascular outcomes, including atherosclerotic process, as well as the 3-point MACE. And very importantly, we have several GLP-1s, and they are generally injectable. We have short-acting GLP-1s, which have been there for a long time, exenatide. Then we have intermediate-acting, which are daily usage, like liraglutide, and weekly as well. These are all injectable. And now we also are going to, means it's there already in some countries. We are also going to have it shortly, the oral GLP-1 as well. So to take you through this journey, especially with regards to some of the GLP-1, including the recent molecule as well, we have none other than Dr. Monojit Ketan Mukhopadhyay, and we are all aware that he is an excellent speaker, and I would hand over the mic to the proceedings to him to carry on with the talk. Over to you, Monojit.
Okay, thank you, Demallo, for the kind words. Just give me a few minutes to start sharing the slides. Basically, I would like to thank the RCPI for asking me to give this talk. Happy Valentine's Day to everyone. And there are various ways to celebrate Valentine's Day. One of them is your love for academics, and RCPI has chosen to have a webinar on Valentine's Day. So thank you very much, RCPI. This group of drugs basically belongs to the specialist, but in this talk, I like to keep it very simple. And what we are trying to encourage the physicians to start using these group of drugs, because they are not only anti-diabetic drugs, and we will see why they stand out or they stand apart from the rest of the anti-diabetic drugs. So this picture on the left is the picture of the native GLP-1 hormone, which Dr. Demal alluded to. And the RA means receptor agonist. That means the native GLP-1 has a very short life because it is broken down very quickly in the bloodstream by the DPP-4. And we have now designed, or these are designer GLP-1s in such a way that they are DPP-4 resistant and they have a very long half-life. The history of GLP-1 goes back to the Gila monster, which was found in the Arizona deserts of USA, and it was found that the saliva of this Gila monster had a very similar homology to the GLP-1. And using that, we have other analogs which are discovered, and we will discuss two analogs in particular. One is liraglutide, which is about 97 homology to the GLP-1. And the other one will be a curtain raiser for an oral GLP-1, which will be the first of its kind. Hopefully it will launch later this year. So this is my agenda for today. So I'll start with the glucose centricity, give you a little background, okay? That type 2 diabetes is a very important disease, not only because of the diabetes itself, but it causes both macrovascular and microvascular complications. The macro includes the cardiovascular and cerebrovascular, and the micro includes retinopathy, nephropathy, and neuropathy. However, a presence of a microvascular event increases risk of a cardiovascular event. That is important. So you have neuropathy, retinopathy, you have increased albumin-creatinine ratio, you have a reduced ABPI, and you have reduced glomerular filtration rate, which is currently called EGFR. And then we have a long duration of diabetes. So presence of a microvascular events increase the risk of CV events. And majority of type 2 diabetes will ultimately succumb to a macrovascular event. And the more the number of microvascular diseases a patient has, so you have 1, 2, or 3 microvascular diseases, in this Forex plot, you can see that the risk of CVD goes up increasing. So does systolic blood pressure, so does diastolic blood pressure, your LDL cholesterol, your BMI, as well as A1C, which is your diabetic control, as well as smoking history. So there are multiple manifestations of these microvascular diseases. And these are some of the landmark trials. It's a summary of that. The UK PDS, okay? And over there, we got tight glycemic control versus relatively normal glycemic control, or the standard of care glycemic control, which was available in those days. It was done almost 20 years ago. And we found that we had microvascular benefits. How? The cardiovascular benefit, macrovascular benefits were initially neutral. However, in the long term, we found some cardiovascular benefits and cardiovascular mortality decrease. These were done with newly diagnosed type 2 diabetics. In the ACCORD study, were done in patients who had diabetes for 10 years or more, and they already had micro and macrovascular complications. In those patients, if you wanted to keep a very tight control of their blood sugars, you got some beneficial results as far as microvascular, but the macrovascular complications were neutral and cardiovascular events were raised, that the CV mortality was raised, pointing to the fact that we need to control blood sugar very early on in the disease in a tight way, rather than waiting for a long time when already complications controlled. And we have advanced and VADT again, basically studies where the patients had diabetes for some duration. And so the bottom line is that you need to have, we can get good microvascular benefits if we use anti-diabetic drugs in the early on in the disease rather than in the later on in the disease. And this is the trend of type 2 diabetes patients from 1990 to 2010. And you can see during that period, the acute myocardial infarction, stroke, amputation, and ESRD did not change very much or maybe slightly increase. However, in UKPDS, that is tight glycemic control results were published, everyone started putting their newly diagnosed type 2 diabetic patients on tight glycemic control. And you can see a dramatic change in the events in these patients. But glucocentricity comes with a price. What is the price of glucocentricity? Particularly if we use drugs like insulin and sulfonylurea, we get hypoglycemia, and that can often be severe, and that increases the risk of cardiovascular disease and as well as death. So again, if you see on the left-hand side in the bar diagram, you can see the tight glycemic control, that is the intensive arm, that is in deep blue, compared to the other, the light blue, which is the standard arm. The more the duration of tight glycemic control goes on, the more you get high risk of adverse events, particularly micro and macro. And you can see on the right-hand side that if this happens, that particularly if they get severe hypoglycemia, okay, major macrovascular events goes up by as much as 3.5. All-cause death goes up by more than 3. CV death goes up by, around more than 3.5 times. So this is extremely important. So what do we have? We are trying to balance A1C with hypoglycemia. However, we have a new concept which is called KG-HbA1c paradox. That means when we try to reduce the HbA1c, that the glycated hemoglobin of our patients, we invariably end up with weight gain and cause hypoglycemia. Therefore, these group of drugs will give you a balance between the two. That means they will give you a low risk of hypoglycemia, good glycemic control, no weight gain or weight loss, and minimal off-target events, and they will give you what we call proven CV benefits. So these groups of drugs not only will help you to control your blood sugar, they will give you cardiovascular benefits, and we will see how they are doing it. So we will look at new drugs which opened up a new dimension of care, and one of them you can see, which is highlighted here, is the GLP-1 receptor agonist. And you can see we have another oral group of drugs called SGLT2 inhibitors, and you can see they have beneficial weight on cardiovascular as well as weight, along with the GLP-1 receptor agonist, which is not shared by any of the other anti-diabetic agents, which you can see over there. The biggest difference between the SGLT2 inhibitor and the GLP-1 receptor, you can see that the efficacy of a GLP-1 receptor is much higher than a SGLT2 receptor. And it gives you other advantages, like it gives you a better insulin secretion without causing hypoglycemia. It has effects on glucagon secretion. It slows gastric emptying, and therefore it produces satiety. So what are the cardiovascular effects observed in the GLP-1 receptor agonists? So we will look into all these, the A1C, the body weight, your blood pressure, your lipid metabolism, and they all work through what we call a process of atherosclerosis, which ultimately, comes on not only with age, and comes up prematurely with patients with type 2 diabetes and increase your risk of cardiovascular death. So let's look at the glycated hemoglobin. So if you look at these group of drugs, you can see on the left-hand side, Dr. Debalashan mentioned about a few of them. Lixisenatide is a postprandial GLP-1 receptor agonist. It mainly works on the postprandial sugars. Then we had exenatide. Exenatide, when it was originally launched, we were using it twice a day. Then we have the extended release preparation. The one we are going to discuss today is the leader, particularly with liraglutide. Then we have dulaglutide, which is long-acting once a week. And then we have semaglutide injections. And then we have oral semaglutides, And as I mentioned, it'll be the curtain raiser for this group of drugs. And you can see in all of these, okay, the cardiovascular outcome trials, the reduction in the A1C was not very significant, yet you got cardiovascular benefit outcomes. So that means these drugs do not only have effects on the A1C, they have other mechanisms of action, as we are going to discuss today, which gives you. However, if you look at the various random controlled trials which are available now, all the bodies have said, in a trial you have two arms. One is the placebo arm and one is the active drug arm. And we have what we call, there's a term over there called SOC, standard of care. So in both the arms, patients will be given what is available in the market at the moment, and we will try to bring the A1C of these group of patients as close to their targets as possible. So these two groups will try to achieve almost the same A1C, and that is called glycemic equipoise. So maintaining glycemic equipoise, you still got cardiovascular benefits. So let's look at body weight. So body weight is one of the hallmarks of the GLP-1 receptor agonist. You can see lixisenatide gave you a body weight reduction in 3 years about 0.7, exenatide 1.3, but liraglutide, which is once a day, gave you a loss in 3 years of about 2.3. Remember, these are average weight losses. So we have patients who are losing much more than this. We have the Rewind giving you a weight loss about 1.5 in 6 years. And the oral semaglutides, we will discuss about the Pioneer 6 later on, about 3.4 kilograms over 83 weeks. And we have injectable semaglutide in different doses, giving a weight loss around 3 to 4 kilos. Let's look at the blood pressure. So it has effects on the A1C, it has effects on your body weight, it has effects on blood pressure. Once again, let's focus on liraglutide and semaglutide. You can see that liraglutide 1.2 millimeter blood pressure drop, Rewind dulaglutide 1.7, but semaglutide oral 2.6, and semaglutide injectable 1.3 versus 2.6. What about effects on lipid metabolism? Okay, because that is one of a very important factor, because it works on atherosclerosis, and you can see they are lipid friendly, particularly if you look at semaglutide, they have a big reduction as far as the triglyceride is concerned. They have moderate action on the HDL-C increase, and they have some reduction as far as LDL-C is concerned. So this is what we have at the moment, the cardiovascular risk reducing trials, okay, with GLP-1. After the, there was a problem with one of the DPP-4 inhibitors, where they were found that one of the thiazolidines, where they found that the use of that drug increased your risk of cardiovascular complications, though it gave you a very good reduction in insulin resistance and blood sugar lowering. So after that, the ADA and a lot of bodies have mandated that you must do a cardiovascular outcome trial, which is called CV outcome. And you can see that these are the various trials which were done, focusing on the leader, which is liraglutide, done in 2016, Sustain 6 with subcutaneous semaglutide, and then we have Pioneer 6 with oral semaglutide, Rewind with dulaglutide, and the ones in green are ones which have been positive and have been completed, and the others like Pioneer 6 in blue are designed for non-inferiority. And there are two other ongoing trials with semaglutide. One is SOUL with oral semaglutide and SELECT with subcutaneous semaglutide in obesity. So what is the missing link in there? So we have benefits on A1C, which is one of the best among all the anti-diabetic agents apart from insulin, giving an A1C reduction close to as high as 2%, body weight reduction around 2 to 4 kilograms, blood pressure reduction anything between 2 to 4 millimeter, lipid reduction lipid friendly on HDLC, triglyceride, and LDL. And let's see what we have. So let's look at the CV risk reduction with the GLP-1 receptor agonist. And as I mentioned, this is independent of the effect on metabolic parameters. So if you look at the various studies which I've just described, that the cardiovascular risk reduction is very high, between 10 to 20 to as high as 25%, particularly with the SUSTAIN 6. However, and the body weight reduction is also between 1 to 5 kilograms. The systolic blood pressure reduction is between 1 to 4, as I mentioned. Yet, they gave you a very big risk reduction. So probably inflammation is one of the missing links, okay, which is helping these GLP-1 receptor agonists to work. And we have experimental and also trials where the native GLP-1 infusions were given to patients with cardiac disease and falling myocardial infarction, and they gave you a benefit and reduction of infarct size in these patients. So how do we measure inflammation? One of the standard markers of inflammation is C-reactive protein. And you can see in Pioneer 1, where they did work on oral semaglutide 3, 7, and 14 milligram. And you can see compared to the placebo, you got a reduction in the C-reactive protein. If we look at Pioneer 2 on the other side, where they compared it with empagliflozin, okay, this reduction with oral semaglutide of 14 milligram was superior to empagliflozin, though empagliflozin has some C-reactive protein reducing properties. So let's look at the anti-atherosclerotic effects of GLP-1. If you look at the LEADER trial, I don't have a slide of that over here, that the arms between the placebo and the liraglutide arm, the arms separate a bit later. That means anything after 1 year. Whereas if you look at the SGLT2 inhibitor trials, the arms start separating very early, within 1 to 3 months. And that is because the atherosclerotic effect takes time to work. So let's look at the target. So what does it target? It targets insulin secretion in a glucose-dependent manner. That means it produces the right amount of insulin, which is needed to get your blood sugar down. And as soon as the blood sugar becomes normal, the effect goes up. And this is called glucose-dependent insulin secretion. And that's why these group of drugs on their own will not cause hypoglycemia. They have a very good glucagon suppression, and glucagon is extremely important in managing your blood sugar. There's a balance between insulin and glucagon. So when you get hypoglycemia, glucagon levels goes up, whereas if you get hypoglycemia, glucagons are suppressed, and that is adequately done by these GLP-1 group of drugs. They have effects on natriuresis and diuresis. They works on the central nervous system. They work on appetite, both at the level of the stomach by reducing gastric emptying and producing satiety. And there are some experimental work where it shows it has effects on cell survival. And you can see over here, it has some work on beta cell survival and function. So the intermediate effects are reduction in inflammation, postprandial lipid reduction, reduction in coagulation, improvement in left ventricular function, and potential neuroprotection. So the final effects of these are, as I want to summarize, is that a reduction in the A1C, reduction in the body weight, reduction in the blood pressure, reduction in albuminuria, reduction in cardiovascular events, and reduction in hepatic injury. So all the major organs, the cardiovascular organ system, the kidneys, and the liver are adequately protected by these GLP-1. So it goes beyond the standard anti-diabetic drugs, where beside the glycemic control, they give you organ protection. So no wonder these groups of drugs have come very high in the list of the guidelines. We look at the ADA ESD 2019, even in the 2021 guideline from ADA, which has been just released, okay, they still come very high. And basically what these guidelines say that Of course, you start with lifestyle changes. Of course, you use metformin. But then first thing to look for in your patient is, do they have any high risk or established atherosclerotic cardiovascular disease? Do they have chronic kidney disease or heart failure? And you consider these group of drugs independent of the baseline A1C or individualized A1C targets. And if they have proven ASCVD, okay, you should consider using a GLP-1 receptor agonist with CVD benefit. Okay, if the EGFR is adequate. However, if the patients cannot tolerate this drug due to some mechanism of some reason, you may use an SGLT2 inhibitor. However, if the patient has heart failure or chronic kidney disease, you should be using a SGLT2 inhibitor provided the EGFR is adequate. However, if we cannot use the SGLT2 inhibitor because of the EGFR, you may also use a GLP-1 receptor agonist, or you can use a combination of these two groups of drugs. So if you look at the cardiology guidelines, okay, they have put these group of drugs very high in the list. They are saying use it even after metformin if the patient has ACVD or very high CV risk. And this is the ACE or the American Endocrinology 2020 guidelines, where they are using, you can see on the left-hand side, even if the A1C is below 7.5%, you can use monotherapy, metformin, and also, or you can, if the patient already has ASCVD, you can use a GLP-1 receptor agonist. So let's see what is the future of these incretins. So I've told you what the story is up till now. Let's see what is the future holds for us. So biggest problem with these groups of drugs was that they were injectable till now. So these are large molecules and they had to be injected. And the fear of injections was a barrier both for the patients and the physicians. And there was a global network internet survey of more than 1250 physicians, and they agreed that having too many injections associated with poor adherence to treatments in patients. And 26% have agreed. So for the first time, we have a GLP-1 receptor agonist, which is an oral, okay? It is not available in India. It'll be available later this year. So as I mentioned, it's a curtain raiser. It's a new route of administration for GLP-1. I won't go into the details of this, okay? It's just, we are excited because this is oral. The problem with this, of course, is its absorption. So the scientists have added what we call an absorption enhancer because it has a very low bioavailability, okay, and there is a variability in absorption. However, because it has a long half-life of 1 week, okay, this low bioavailability with the absorption enhancer gives you the option of using a once daily dose, first thing in the morning, empty stomach. And there are various treatment issues we will discuss in the later talks. So these group of drugs, oral semaglutide, as I mentioned, their clinical trials are called Pioneer, that is called Peptide Innovation for Early Diabetes Treatment Clinical Trials. And there are 24 clinical pharmacological trials, 1 phase 2 trial, and 10 phase 3A clinical trials. And in these trials, more than 9,500 patients have been enrolled, and the subject exposed to oral semaglutide are around 5,707. And these are the various Pioneer 1 to 10 trials which have been completed, and there are some going on. So Pioneer 1 is monotherapy versus placebo along with diet and exercise. Pioneer 2 is add-on to OAD versus SGLT2 inhibitors. So these are good head-to-head on studies. Pioneer 3 versus DPP4 inhibitors. Pioneer 4 is versus GLP-1 receptor agonist stroke placebo. Pioneer 7 is a flexible dose adjustment versus DPP4 inhibitors with extension. And then we have studies with insulin users, which is Pioneer 8, which is add-on to insulin. And we have 51 Indian subjects in this. You see, whenever a drug is launched, we always say, where are the Indian studies? So the company has decided to use Indians and Asians in these studies. Then we have Pioneer 9, which is done in Japanese studies in the Asian population versus liraglutide and placebo. Pioneer 10 is versus dulaglutide, which is the once a week GLP-1 receptor agonist. Then Pioneer 6 is those with renal impairment. Pioneer 5 is going with renal impairment. Pioneer 6 is CV outcome trials, where 201 Indian subjects have been enrolled. And there's an ongoing trial with which is a superiority trial, okay, which is called SOUL, where about 650 Indian subjects have been enrolled, and total number of Indian patients involved in these studies are 902. So we'll get a lot of data as far as Indians are concerned when these trials, some of these trials are released. So let's look at what has happened in these trials, okay? So let's see the change in the A1C with oral semaglutide versus comparators. So monotherapy with increasing doses. So with advancing doses or graduating doses from 3, 7, 14, okay, compared to placebo, you can see an increase in a drop in the A1C from 0.9 to 1.2 to 1.4. If you're comparing with EMPA, it was found to be superior, 1.3 versus 0.9. Compared with CETA, again, if you're looking at 14 milligram of sema, it is 1.3, or 7 milligram, it's 1. Compared to liraglutide, okay, it is sort of neck to neck compared to liraglutide, which is injectable versus this oral at 26 weeks. Pioneer 5, which is renal, 1% drop compared to placebo. Pioneer 7, which is a flex study for about a year, okay, with sitagliptin 1.3 versus 0.8. And Pioneer 8 with insulin, which is 26 weeks, again, with increasing doses 0.6, 0.9, and 1.3. So we have a very, very important, robust A1C reduction. So it's an unsurpassed HbA1c reduction. So let's look at change in body weight with this oral GLP-1 receptor agonist. Again, with monotherapy, okay, at 26 weeks, improved A1C reduction. Again, the same things, EMPA, CETA, and you can see this gives you a very, very good body weight reduction, much more than its comparator, anything around 4 kgs body weight reduction. What about achieving A1C targets below 7%? And you can see with increasing doses of semaglutide, this is going up from 55 to 69 to 77%. Okay, 67 versus 40 with empagliflozin. Okay, and even with lira, it is almost neck to neck, 68 versus 62. So you got 77% of patients achieve the A1C target of below 7%. And you know, it comes with all the advantages of a GLP-1 with weight loss, A1C reduction, no hypoglycemia. What about the safety efficacy? Safety is very important across the Pioneer clinical program. So we have there was a large safety database for oral semaglutide. More than 5,700 patients were enrolled, and the main side effects were GI, and they were very mild to moderate and at short duration. Unlike the injectable GLP-1s, which they had a much more severe GI side effects. Oral semaglutide was associated with low rate of severe hypoglycemia, and no new or unexpected safety findings were found with oral semaglutide. It was well tolerated, much similar to, probably even a little bit better as far as GLP-1 receptor agonists are concerned. So the take-home message basically is that 3 out of 4 people with diabetes in India fail to achieve glycemic targets, okay, for multiple reasons: cost, injectable, side effects. And these are very well taken care of by these group of drugs. Good glycemic control with more people achieve targets without hypoglycemia. And there is a substantial weight loss, which is across different populations. And that is what you see. The GLP-1 receptor agonists with proven glucoviscerometabolic advantage over the other antidiabetic drugs is what we are looking for. And major guidelines like the ADA, ASD, ACE all recommend GLP-1 receptor agonists as the first line of therapy in patients with established CVD or those with high CV risk. Oral semaglutide is an innovation with a great potential to pioneer a new era of achieving glycemic targets with convenience of oral administration, which has eluded us as far as the GLP-1 receptor agonist till now. So thank you very much for your patient hearing. I'll stop sharing the screen and then I'll...
Thank you, Monojita, for an excellent talk and overview. It's very interesting. And recently, just this week, in NEJM, there was a publication of the SELECT trial showing subcutaneous semaglutide, having a whopping 15% weight reduction. This is probably the largest weight reduction with any therapeutic agent other than surgery. Bariatric surgery, of course, can cause further reduction, but this is the largest weight reduction possible with any of the anti-obesity drugs. So we already have liraglutide approved as an anti-obesity, but at a much higher dose of 3 milligram. And now we have this data as well. So if there are any further questions, would like to...
Dr. Sujoy Majumdar would like to comment. I'm sure he's got a lot of experience with liraglutide.
Yes, and we also had this experience with low dose liraglutide 0.6 milligram. We have published data which showed both glycemic and weight control. And by far, we also compared Dula with Lira as well. And we have seen that, long term, even with a dose of 1.2 milligram, probably we have a much better glycemic control to the tune of 1.5% and a weight reduction, which is much more than what is reported in clinical trials. And this is probably much better than even dulaglutide. That is what we have the experience, because these are relatively shorter acting agents. So probably they have more impact on weight as well. So with regards to use in as an anti-obesity drug, do you have any experience or any comments, Monojita?
I don't, Dr. Sujoy Majumdar has used it. I'm sure he'll be able to answer it. I don't use it as an anti-obesity drug because I struggle to get my patients to that 3 milligram dose. Most of us, we get stuck at 0.6 and 1.2. Okay, so getting them
to be
up.
Very honest.
Your experience.
Yeah, to be very honest, I mean, to the best of my knowledge, liraglutide in a dose of 3 milligram is still not licensed in India to be used. So wherever you have used it is as an off-license indication. But I had a couple of patients who were too keen to cut down their weight. They were not willing to go for a bariatric surgery. And on these patients, we gave this sort of a dose, and it showed a substantial weight loss of around 5 to 6 kg in a span of 3 to 4 months. So this is something which we noticed. They continued it up to a period of nearly 6 months, and altogether had a weight loss of around 8 kg. So that is only my experience with this liraglutide 3 milligram. But yes, what Debmallo has said right now, I mean, if it is showing a weight loss of 15 kg. Now, something which I'd like to know, Debmallo, was it a sort of a double-blind placebo-controlled trial, or was it a head-to-head trial with any other GLP-1?
No, this was a SELECT trial, which was just mentioned, which was just published last week. SELECT trial included injectable semaglutide, and that was basically a placebo-controlled trial, and that showed 15% weight reduction. So this was primarily, as Monojita actually had quoted in his presentation, the SELECT trial. This was published in NEJM this week. So this is with regards to injectable, not the oral semaglutide. It's with the injectable semaglutide, weekly injectable semaglutide.
Now, this is quite interesting because the other weekly injectable GLP-1 that we use, that is dulaglutide, actually showed a much lesser degree of weight reduction in comparison to liraglutide. I mean, the difference is of the order of 700 grams. Yes. The head-to-head comparison between liraglutide and dulaglutide showed a much lesser degree of weight reduction with dulaglutide.
Yes.
So I was just wondering, I mean, with semaglutide, if you're getting such a huge degree of weight loss, what is the expected mechanism? Does semaglutide cross the blood-brain barrier to that extent, so as to basically affect the hypothalamic pathway of appetite and those things? Does it do it like that?
So probably that will be the explanation, because with the longer acting preparation, there will be less impact on the gastric emptying. That's why the shorter acting preparations are more effective as weight reducing, because they reduce the gastric emptying and they also cause more side effects.
Yeah, yes.
But this is probably because of the longer acting, and probably rightly pointed out, this may be one of the reasons why they are having more amount of weight loss as
So
well.
did they use semaglutide in the same dose as what did you do for a diabetes like the Pioneer trials? Did they use it in the same dose?
Yeah, well, I would need to check at that. I haven't checked at that. Probably they were using at the same dose. I wouldn't really. But there is also one data which is also there with dulaglutide of 4.5 milligram as an anti-obesity drug.
Yes.
Yeah, they have also shown some effect. So that is something. So probably because obesity is also a very difficult problem to tackle. We don't have medication. So probably this may be future agents. We don't have any agent other than probably most of the drugs are contraindicated, which were used. They have now gone. They have now been banned with regards to obesity. That's an unfortunate problem with that. Now, with regards to diabetes, Monodidda, with regards to this obesity, there is one view which is there with diabetes and weight loss, that about 25% have weight loss and 25% do not respond, and 25% just respond to glucose control, and 25% only respond to weight. Your take on that? What has been your experience?
You see, what I tell my patients, and this happens also with the SGLT2 inhibitor. It is a biological system. You do not know how your patient is going to respond to a particular drug. We do not have any method to find that out. Okay, definitely we find that about 25%. You're right, up to 50%. In fact, I would say up to 50%, provided they can tolerate the medication. And as you mentioned, you have a study, and we've done also some work where we started with smaller doses. Okay, started with 0.3 instead of 0.6, which is the starting dose, and we gradually build it up. And I've been able to build these patients up to 1.2 without any having major side effect in a very graded manner. So we have had patients who've lost 15 to 20 kilograms as well. Okay, and we had on the other hand patient losing only 1 to 2 kilograms. So our experience with the SGLT2 inhibitor is absolutely the same. But you have to remember that the benefit of these drugs is not only limited to A1C control and weight. They have other benefits, as you saw, on inflammation. Same with SGLT2 inhibitors. I mean, if the patient doesn't lose the weight, you don't take them off that drug. Okay, because the other benefits, particularly the cardiovascular and the renal benefits, for example, liraglutide can be used with the EGFR up to 15. Okay, so these groups of drugs have other pleiotropic benefits, like statins. Statins nowadays are not a lipid-lowering drug; they are cardiovascular risk-lowering drugs. So we encourage our patients to continue with these groups of drugs. Okay, till there are some problems or contraindications or whatever it is.
So that is precisely the reason I brought this up, because we need to continue with these drugs, especially in high-risk patients with cardiovascular issues, to prevent cardiovascular events and mortality as well. So that is very important. Some patients may not have adequate significant amount of glucose lowering or especially weight lowering, but we need to still persist with these agents. So with these words, I think we are running short of time.
Just before you end, just a final comment here. There is actually
any question available. Excuse me, you should invite some questions from others. You have discussed amongst yourselves.
I don't think we are finding any questions on the chat box.
There is no question in the chat box. There's no question.
No question.
Sir.
So we are talking actually.
If there are anybody can
Demallo, if you may allow me, I go ahead with my question.
Yes,
so
yes.
basically,
Hello.
Hello.
Type in your question. Please type in your question.
Type your question. Please type your question.
Please type your questions, or if necessary, you can unmute yourself. And
I want to talk to Dr. M.K. Mukhopadhyay.
Yeah, who's that?
Yes, I myself, Dr. Ajitesh Ghoshal, sir.
Yes.
Sir, I'd like to ask you one relevant question. How will you choose? which patient you will give SGLT2, which GLP, which patient GLP-1 analog? Yeah, how will you differentiate?
No, see, you look at the guidelines. The guidelines say if the patient has atherosclerotic cardiovascular disease, you should offer the patient a GLP-1 first. If for some reason the patient does not want to take an injection or the cost is prohibitive, okay, then you think of a SGLT inhibitor. Whereas if the patient has heart failure or it has CKD, there you would like to use an SGLT inhibitor, provided the eGFR is adequate. I mean, 30, is the cutoff. Maybe in the future it'll come down to 25 or 20. So these groups. However, if the patient needs a SGLT2 inhibitor and you cannot use it, your next choice is a GLP-1. So these are the main ways in which you want to distinguish between the two, as far as the guidelines are concerned.
So
Yeah,
final
Deval,
word from Sujata, and then we would hand it over to the
just a comment regarding the weight loss, because I think this was one of the primary issues that we discussed today. Regarding the weight loss, with if you compare the effects of GLP-1 versus SGLT2 inhibitors, what we often tend to find out, and this has been our experience, this has been seen in studies also, that the weight loss with SGLT2 inhibitors, it tends to plateau off after maybe 3 to 4 months. And after that, these patients, they do not lose any further weight. Whereas with the GLP-1 receptor analog, particularly the ones with a human backbone like the liraglutide and semaglutide, you keep on losing the weight. And this is a continuous process. So for a patient who has got obesity with diabetes, who is finding it difficult to really get his weight control, we have to remember something, that obesity control is often multifactorial. It's not always that the patients do not try to cut down the diet, but at the same time, they're unable to exercise. And the case that Monojit mentioned, that the patient lost around 20 kg, what we have often seen is that a patient, once he starts losing the weight with liraglutide, they keep on becoming more active. And this is something which adds to the further process of the weight loss. So in that way, actually, GLP-1 receptors agonists are probably more weight-reducing drugs, or more pro-weight reducing drugs than SGLT2 inhibitors.
Yeah, sure.
May I ask a question as a non-diabetic?
Yeah.
I am very amazed to see that a very impressive drug that Monojit has mentioned about coming in the later part of 2021. What would be the cost? Would that be affordable to commoners? And what would be the approximate cost?
So we have no idea because the drug has not been launched. The company also doesn't know what might be the cost.
Oh.
But they know they have a surprise up their sleeve. So, but you see, since they're going to compete with the injectables, they keep it sort of a competitive cost, as I would put it that way.
As most of the things that we know in a medical history, whenever a new drug comes, we think that's a panacea of that particular problem, and then another one comes and takes over. So hopefully this is going to be an exception. Thank you for your presentation. And I think, Sujay, please go ahead with your...
Yeah, may I now invite Ronojit to say the final words and Thanksgiving.
Thank you. Good evening. Can you hear me?
Yes, you're audible.
All right. That's a great relief. Actually, for the last 2 times, I have been bestowed upon this responsibility to give the closing remarks and thanks. But unfortunately, both the times I missed it. It was a long evening today, that too a Valentine's Day evening. But it was never boring. It was really interesting to listen all through. And as before our participants leave, first of all, I should thank them that even today they were sitting with us patiently, around 30 to 40 of them. So without you, this webinar wouldn't have been possible. So thank you so much to be with us. And again, before I forget, I'll definitely thank Devashish and his team, who is relentlessly working for our CPI to make our webinars with the 6th one and to make it successful. And as Dr. Dinesh Jain, one of the pillars of our society, he started with the words that dissemination and sharing of medical knowledge, that's what we are trying to do here. Thank you, sir, for your encouraging words. And obviously, Dr. Sujay Majumdar, our Vice Chairman and to the Master of the Ceremony, he basically managed the whole thing very well. I'll start with Dr. Devmalya, my dear friends, and Dr. Manojit Mukhopadhyay's beautiful discussion, and Dr. Roy's question actually, which came from the heart. 72 million, around 73 million people in India is suffering from diabetes. 14% are in the urban areas, around 10% in the rural areas. A new drug that you have offered today, the Valentine's Day evening, semaglutide, oral semaglutide, will it be reachable to our poor people? Can we manage what we are saying today? Can it reach to the general masses? That's the big question that definitely needs to be answered. Otherwise, it was an excellent discussion, fantastic discussion. Thanks to both of you. The same thing when I go for Dr. Shushmita Banerjee's lecture. Really, pediatric nephrotic syndrome is coming up in a great way and being diagnosed by pediatric nephrologists nowadays. I know Dr. Bijan Bhattacharya practicing nephrology for the last, I think, 40 years or so. And I still feel we don't have adequate pediatric nephrologists all over India. So our pediatricians should be trained, and they're doing this very well in treating the nephrotic syndrome patients. So if we go on subspecializing our specialties, can we afford in a poor country like India, where do we have that amount of subspecializations? This is a question that has to be definitely, we should try to introspect. Fantastic lecture, lot of knowledge we gained from your nephrotic syndrome that we are also practicing some of them. Yes, it definitely increased and improved our knowledge. Sagarika was completely, Dr. Sagarika Mukherjee is completely in a new avatar today. She should have been also discussing this endocrinology part, the diabetes part, but her newfound interest in medical ethics, and also it rejuvenated some interest in us also. Very, very interesting case reports, and that also is an eye-opener for us and will make us more cautious, because we are seeing that the deteriorating relationship between patients and doctors nowadays. So that is very important topic. I think the Royal College Indian chapter has done an excellent job in keeping this type of topic. I also, if I have forgotten someone, I have not forgotten the most important person. Lastly, I'll thank him, because I don't have any word in my dictionary for the man who is for the last 15 years, 16 years, is trying to fly our flag high in India and also in Asian countries. And today we are here mainly for his dedication, for his perseverance. Dr. Sabyasachi Ray, sir, our mentor, our chairperson. I have no words for to say thanks to you, because that will be less for you. Whatever we are today, we're sitting here. It is only mainly largely for your dedication that you have dedicated your life for the last 16 years for us. Thank you, sir. Thank you so much. And if I missed somebody, our chairpersons, yes, one of us, he was invisible today, Dr. Deepak Sharma. But your words are very eloquent, and thank you, sir, to be joining us for the first time, I suppose, in our webinar. Thank you so much. Thank you all of you again, and I say good evening to all of you again. Thank you so much.
Thank you, Ronajit. I think the last but not the least, Novo Nordisk must be thanked profusely for sponsoring the talk of Dr. Manojit Ketan Mukhopadhyay. And I think the other thing I would like to mention, that you said about the other face of Sagarika Mukherjee. She already mentioned that she's now trained in medical ethics as well, and she has got a degree, or diploma, I'm not sure, but some kind of course which has gone through. You'll be the right person to guide us along in future if we are in trouble. So I think it's a very, very well-versed period has been finished with the 6th lecture, and now I request the webinar group to stay for a few minutes, and others, thank you very much for joining, and we will have a few minutes discussion before we end. Thank you very much, all others.
Thank you, everyone. Thank you, everyone. Okay.
Thanks, everyone.